Great. Okay, welcome everyone. Today we are talking about gestational hypertension, specifically hypertensive disorders in pregnancy that we see in the ED. This slide is as chaotic as the disorder can be, showing a few of the different factors that is involved and what kind of chaos it can cause inside the maternal body. So that's our topic for today. So just looking at some of the statistics, the global prevalence is somewhere between 5 and 8%, obviously more in Africa, up to 10%, and some studies have showed primary gravidas South Africans even up to 13%. And 18% of all maternal deaths that we see in South Africa can be attributed to hypertensive disorders in pregnancy. 75% of these could have been preventable, and 80% of these are shown to be at levels of care where specialist care should be available. And that's talking directly to our level of care and the patients that we see in the ED. These are very scary statistics. So looking at some of the definitions in the diagnosis. So chronic and essential hypertension is defined as a systolic blood pressure of 140 or more, a diastolic of 90 or more, and this must happen on 2 separate occasions that are at least 4 hours apart, or one reading of more than 160/110 millimeters of mercury. This also must be before 20 weeks of pregnancy, otherwise we cannot really call it chronic or essential hypertension. If it occurs at 20 weeks or after 20 weeks of pregnancy, this is then defined as gestational hypertension. We get preeclampsia, which is gestational hypertension and includes mild and severe preeclampsia with various levels of organ dysfunction and proteinuria. For example, we can see increased liver enzymes, decreased platelets, or even placental insufficiency in the form of intrauterine growth restriction. We also get imminent eclampsia, and this is when the patients come in with symptoms such as headaches, visual disturbances, epigastric pain, hyperreflexia, dizziness, vomiting, and fainting. We get eclampsia as well, and we actually see this quite a lot in the ED. Patients come in generalized tonic-clonic seizures. This must be after 20 weeks of pregnancy or even within 6 weeks after delivery, and it must be associated with hypertension and proteinuria, and there must be no other obvious cause of the convulsions in order to diagnose this as eclampsia. We also get HELLP syndrome, which stands for hemolysis, elevated liver enzymes of an AST or ALT of more than 70 to 80, low platelets of less than 100, and this again must be in association with hypertension and proteinuria. So there's a lot of normal physiological changes that do occur in pregnancy. This slide focuses just on the cardiovascular changes that we see, and again, this is all normal changes. So the blood volume can increase up to 50%, and this results in increased blood flow to uterus, kidneys, skin, as well as for the metabolic needs of the fetus. The plasma volume increases even more so than the red blood cell volume, and this leads to a physiological anemia. When we get the diastolic blood pressure decreasing between 5 and 15 millimeters of mercury, systemic vascular resistance decreases as well, up to 20%. Heart rate increases up to 30%. Stroke volume and cardiac output increase up to 50%, and with the cardiac output, a full 10% goes directly to the uterus. This maxes out at about 24 weeks of pregnancy, then that is maintained up until term. It peaks even more during labor and after delivery, where there is the highest risk of cardiomyopathy. This then returns to baseline about 2 weeks post-delivery. Also have pulmonary arterial pressure, which decreases about 30%, and the left ventricular wall thickness increases up to 30%. Now, much more normal physiological changes that do occur, and this slide just shows that it involves almost every organ system in the body. I'm not going to go through all of them, but I just want show you that this does affect all of the systems, including pulmonary, GI, and liver, as well as renal and hematological systems. Let's just go on to the pathophysiology of pregnancy-induced hypertension specifically. What we do know is that it's still not completely understood. We know that it is a multifactorial thing involving genetic susceptibility, environmental and maternal characteristics, as well as immune inflammatory factors. So there's about 2 rounds of normal uterine vascular remodeling that occurs in early pregnancy with the development of the placenta. The first one happens very early in the first trimester, and the second one around 18 weeks, just after the first trimester. This 18-week one is seen as the more important one in the development of pregnancy-induced hypertension. What happens is, instead of the normal vascular remodeling that allows for good blood flow and perfusion to the placenta, we get spasming of these vessels that result in placental hypoperfusion and hypoxia, resulting in placental dysfunction and the release of anti-angiogenic factors from the placenta into the maternal circulation. This results in widespread endothelial damage and dysfunction, resulting in hypertension, proteinuria, HELLP syndrome, as well as eclampsia. In terms of maternal complications, we have acute and long-term. For acute, we see eclampsia, pulmonary edema, HELLP syndrome, CVAs and MIs, renal dysfunction, acute respiratory distress syndrome. We also see posterior reversible encephalopathic syndrome, which is a white matter vasogenic edema that affects the posterior occipital and parietal lobes of the brain. It's characterized by seizures, altered mental status, and visual loss. Most patients do recover, but it is not always reversible. Otherwise, they can have cortical blindness, DIC, and subcapsular hematoma, which can lead to liver rupture. Long term, we do see chronic hypertension, end-stage renal disease, postpartum cardiomyopathy and heart failure, vascular dementia, CVAs and coronary artery disease, as well as ischemic heart disease. In terms of the neonate, acutely we can see intrauterine growth restriction resulting in low birth weights, preterm birth. We also see placental abruption, neonatal respiratory distress syndrome, neonatal thrombocytopenia, as well as bronchopulmonary dysplasia. Long-term, they can actually develop hypertension, cardiovascular disease, hormonal abnormalities, delayed sensory motor reflex maturation. They can also have CVAs as well as grow up with an increased BMI. When we see these patients, we need to make sure we have accurate BP recordings when we are assessing them. And that means that in order to measure BP correctly, they need to be in a relaxed sitting position, trying to keep the arm at the level of the heart, using an appropriately sized cuff, which sometimes we don't have access to. Make sure we are using a validated device. If we do have multiple values, always rely on the higher value. Let it be safe than sorry. And then if the blood pressure is borderline, best to keep the patient, repeat it in 2 hours, or even consider asking them to come back in 3 to 7 days if they are otherwise stable. In terms of history, we look at prior pregnancy-induced hypertension and PE history, if they have diabetes, chronic hypertension, lupus, antiphospholipid syndrome, if they're currently carrying multiple gestations, previous pregnancy complications, as well as postpartum complications. These patients usually present in one of 3 ways. They can come in asymptomatic with symptoms of preeclampsia or eclamptic. In terms of asymptomatic, these are usually patients we see being referred from clinics with high recorded blood pressures. They usually don't have any symptoms, or if they do have, it's very mild symptoms with no signs of severe disease. They can come in with preeclampsia, so symptomatic such as headaches, blurred vision, chest and abdominal pain, shortness of breath, and hyperreflexia. They can also have decreased urine output and proteinuria on dipstick. Or they can come in very severe eclamptic with generalized tonic-clonic seizures. Important to note that our differential diagnosis, we need to be aware of these and not just hone in on pregnancy, seizures, most likely preeclampsia or eclamptic. So we need to look at their risk for CVAs, meningitis, having a pulmonary embolism, pleural effusions, coronary syndromes, heart failure, also aortic dissection. There are also other liver pathologies of pregnancy, such as acute fatty liver of pregnancy. They can also have hyperaldosteronism, hemolytic uremic syndrome, or even just an acute exacerbation of lupus. In terms of the liver pathologies in pregnancy, I just wanted to highlight how similar these can be, the acute fatty liver of pregnancy, preeclampsia, and HELLP syndrome. So we don't see this very often, but it's important to note that acute fatty liver pregnancy does happen, and they usually come in complaining of right upper quadrant pain and jaundice in comparison to preeclampsia or HELLP syndrome, where they have hypertension with the right upper quadrant pain or epigastric pain, but no jaundice. However, with all three of these, the treatment is to stabilize, treat blood pressure if necessary, and consider immediate delivery. So this is just a very, very quick overview about the treatment, which I will go into detail in each slide, just so we can see clearly in this map over here. Patients either come in asymptomatic or hypertension, but with no proteinuria. We can start giving them alpha-methyl dopa, which is the preferred antihypertensive agent in pregnancy. We can give up to 500 milligrams TDS, ensure that they are being followed up correctly in a good ANC clinic such as ours, which we can refer to. We can also consider giving them aspirin. We give 150 milligrams daily, especially in patients that are high risk, so previous history, chronic hypertension, multiple gestations, history or diagnosis of lupus or APLS. And also with this, it's important to note that we need to stop aspirin at around 32 weeks of pregnancy. Then they can come in with features suggestive of preeclampsia, symptoms that I've mentioned earlier, as well as proteinuria. It's important to confirm the diagnosis as well as establish how bad the organ dysfunction is, so in terms of bloods and sona as well. And then refer them up to a good ANC, or even if necessary, involve obstetrics when we do see them, especially in terms of planning the delivery, especially an earlier delivery. They do come in with preeclampsia or eclampsia. It's important to stabilize the patient downstairs in the ED. We should consider steroids if the gestational age is less than 34 weeks, and then involve obstetrics early, as they are most likely going to opt for a very early labor or immediate delivery. Okay, so the investigations that we do, bedside tests, we do urine dipsticks, blood gas, and ECG. It's important with this, especially with the ECG and the blood gas, we are also looking for other differential diagnosis to rule out, especially with the ECG, looking for cardiovascular issues, pulmonary embolism. And then blood investigations, we do the PET bloods, which is FBC, UNE, AST, ALT, and LDH, especially in cases where obstetrics might put the patient directly to theatre from us. So we try and get those bloods done as soon as possible. And then we can also consider doing a urine protein creatinine ratio, but that's usually done by obstetrics themselves. In terms of imaging, downstairs we can do the POCUS, have a look at the fetus as well, consider chest x-ray and CT brain, especially in terms of looking at other differential diagnoses. Okay. So in terms of management, must always remember to go with the ABC approach, especially in these patients. Airway, breathing, circulation, these are very important, especially when they come in eclamptic. So never forget our ATLS principles. So severe or imminent preeclampsia, make sure we have a patient on a bed with monitors, have IV access, preferably 2 large bore IVs. We can preload the patient with 200 ml of renal lactate. We can consider MagSalve. I'll go into the doses in the next slide. Should insert a urinary catheter as well as do PET bloods. Inform obstetrics early on. They do come downstairs. They do see the patients in ED, usually if we involve them early on. Try to assess the uterus as necessary, see for tenderness, liquor volume, and also to rule out a placental abruption. Assess if the patient is in labor. And also don't forget that these patients are in pain, so treat their pain, however, trying to avoid giving them NSAIDs downstairs. They come in eclampsia. We need to first call for help. We involve obstetrics, peds, as well as anesthetics as far as possible. Try to keep the patient as much on the left lateral as possible as well to avoid aortocaval compression. However, always being aware of our airway being more important. We need to manage that airway, clear secretions, and use our airway adjuncts. These patients are notorious for being one of the most difficult airways you see, so anticipate that. Put them on high flow oxygen, and then give MagSalve loading and maintenance. So this blue image here on the right is taken directly from our ED protocol book, and this is what we use. We load with 4 grams of IV MagSalve, bolus over 5 minutes. We can actually put this in a 200 ml of normal saline as well to preload with that. And then we do an infusion of 1 gram per hour. So that's 10 grams that we mix with 30 ml of normal saline, and also giving that at 5 ml an hour. If the seizures do not abort with this, we can consider giving an additional 2 grams of MagSalve bolus again over 5 minutes, or even consider giving a clonazepam 1 milligram IV if the seizures still do continue. We need to treat the blood pressure. So for that we use IV labetalol. That is our gold standard. I'll go into the doses in the next slide again. And then steroids, especially if the pregnancy is less than 34 weeks. We use betamethasone 12 milligrams IMI, which gives us 12 hourly for 2 doses. So we try and get that first dose in as soon as possible downstairs, especially in cases where patients are most likely to go directly to theatre. You should always prepare for a definitive airway management, and that can go as far as intubating the patient, and this is why we always prepare by calling anesthetics, keeping our airway trolley nearby, difficult airway trolley, and all the equipment that we might need for that. Then for IV fluids, so the protocols usually say that we need to restrict IV fluids to 1 ml per kg an hour, up to a max of 85 ml per hour. And some of the protocols are different. Some say 70, some say 85. But it's important to avoid fluid overload here, because even though the patients are intravascularly depleted, they are at very high risk of fluid overload and pulmonary edema. And then we always insert the urinary catheter, aiming for 25 ml per hour of urine output. Unfortunately, the only definitive treatment for this is delivery, and at the same time we need to be aware and prepared to treat for any possible complications that can arise during our treatment. In terms of MagSalve, we can actually also do the IMI route, which is 5 grams of MagSalve in each buttock as well, then followed by the infusion. So let's talk about the BP lowering agents that we use. As I've said, labetalol is the first line gold standard treatment that we use for preeclamptic and eclamptic patients. It is an alpha and a beta blocker. It should ideally be used in high care and emergency settings only, but our ED definitely does count as that. We use it in patients with a systolic blood pressure of more than 150, diastolic of more than 110, and a MAP of more than 125. We give 50 milligrams IV over 5 minutes, and this can be repeated one more time. Then we go with an infusion of 50 milligrams per hour, which can be increased every 15 minutes up to a maximum of 200 milligrams per hour. Labetalol is contraindicated in patients with asthma, congestive heart failure, and heart disease. But at the same time, it does have fewer side effects than our other agents that we have available. For maternal, we have postural hypertension, wheezing, and fluid retention is the most common side effects. And then in terms of the fetus, there has been no study showing any significant teratogenic effects. However, in high doses of labetalol, they have seen neonatal hypoglycemia, and they've also noted that it is secreted in the breast milk, which can result in the decreased blood pressure and heart rate of the neonate. We also have hydralazine, which is an arteriolar vasodilator. It is a second-line agent to labetalol, and we give 5 milligrams IV bolus, and then an infusion of up to 10 milligrams an hour IV. There is a bit of a higher risk of hypotension and fetal distress, as well as tachycardia when we use hydralazine. And then lastly, I have put down nifedipine, but please don't use it. It is a calcium channel blocker. It is our last option. I've only put it here because most of the patients that we see coming from clinics in the peripheries have usually been given nifedipine orally at those levels. And it is very cheap and freely available. The government is trying to get rid of it, especially in the clinics, but there's just so much available that it is being used, unfortunately. They usually give 10 milligrams PO stat, and they usually repeat every 30 minutes or so. But there's significant side effects, especially hypertension, and especially because some of these patients go home with the nifedipine and is used in settings where they are not being monitored. So just so that we are aware of nifedipine and that it is being used. I know Discoverers is still using nifedipine, unfortunately, and we do see patients from there quite often. But yeah, thank you. This is my references, and thank you for listening to my talk.